Hello, everybody, and welcome to the Hughes Clues, ABGs, and acid-base balance. And there is an overwhelming amount of material that's presented in the critical care course. And as you begin this course, my suggestions for your study would be that you do the Hughes Clues presentations, print out the ABG or any of the worksheets that connect with the Hughes Clues presentation. And then as you listen to the recording and I ask a question, pause the recording and then write the answer to the question that I'll relay in the recording. So I say do a play, pause, write. This will help you to understand and retain the information because you're going to be asked questions in a very challenging manner, and the more you understand and the more you can remember the information, it will be much easier for you to answer the questions on Dr. Reed's exam. So we're going to start with acid-base balance and why is acid-base balance important to maintain. And I know many of you have learned about acid-base balance in probably several of the other courses that you've done. My focus here is to kind of give you a little bit of an A&P review, a pathophysiology review, so that you can again understand it very well and be able to successfully answer the challenging questions that are presented on Dr. Reed's exams. So when we talk about the body, we know that pH or acid-base balance is, of course, a factor. And when you look at the pH, the range of pH is anywhere from 1, which is very acid, to 14, which is very alkaline. And as the body does its metabolic workings, it constantly produces acids, and these acids have to either be neutralized and then they have to be removed. And so that's how your acid-base balance or your pH in the blood is maintained. So what is the normal pH range, and what is the term used if the patient is above or below that range? So if we think about it, when we said that there was acid was at its most as at a 1 and then alkaline at a 14, it would seem to be reasonable that the body's pH would be right smack in the middle of 7, and that's just not the case. You can see that the range is anywhere from 7.35 to 4.5, and number one, that's a very, very narrow range, but it's also in the slightly alkaline range, which is, as we discussed, the fact that the acids are already what I consider to be pooping out the cells are constantly pooping out acid as they do their metabolic function, and that's why the normal pH is usually kept in a slightly alkaline range. If the pH goes above 7.45, this is an alkalotic state. If it's below, it's an 7.35, then it is a acidotic state. So how is the pH range maintained, and why is it so important to keep it in that narrow window? Well, as I mentioned, the cells do their metabolic workings, and in any range outside of the normal pH, then the cells do not do their job. They do not make ATP, and stuff stops running. So the normal pH range is maintained by the buffer system. It's maintained by the respiratory and the renal system, and these all work on their own, but they do kind of coordinate with each other and work together, but each one works at a different speed. So one of the buffer systems is the bicarbonate and carbonic acid. So how does that work? Well, bicarbonate and carbonic acid is basically your body's chemistry set. As soon as the cell, after it's done its metabolic workings and it poops out an acid, then the bicarbonate carbonic acid that is always present in a blood in a 1:20 ratio will immediately jump on that strong acid and then do a little chemistry maneuvering with the H's, the C's, and the O's. And as it does that, then the strong acid is converted into a weak acid. Once the acids are now weak, then the respiratory system or the renal system can permanently remove the acids. So that's how it works. The buffer system makes the strong acids weak, and then the respiratory and the renal get rid of those weaker acids. And if you think about the buffer system, it's essentially like a sponge. It has only so many chemicals, and if once those chemicals have been utilized, then they either need to have more produced or they're going to be overwhelmed. They can only soak up so many strong acids, and so this becomes a problem whenever the body is cranking out a lot of acids with a greater speed than what the bicarbonate carbonic acid buffer can handle. The cell also can act as a buffer, and of course, it kind of does it in a very subtle and unique way. It doesn't really get rid of anything, it just hides them. So the cell, consider it to be a house that only has so much space for substances. And let's say, for instance, this red bar here, that's meant to represent the blood space, and if whatever is happening in the body the cells produce a lot of acids, then those are represented by the hydrogen ions here, and as those numbers of hydrogen ions increase in the blood, then the body will shove these hydrogen ions into the cell to kind of hide out for a while, so that can help to bring up the pH that is acidotic because of all of these acids or hydrogen ions that are present in the blood. But the cell only has so much room in its house, and whenever the H's are occupying the space, then the cell has to kick out another substance to make room for those H's, and the substance that it kicks out, or the electrolyte that it kicks out, is potassium. So this will happen in the reverse if there is an alkalotic state. So know again that the cell can very, very quickly respond by moving hydrogen ions in and out of the cell depending on what the acid-base state is in the blood. Now, how do the lungs and kidneys factor into this maintenance program of the normal pH? Well, what do the lungs do? The lungs help by excreting the CO2, that weak acid. And anytime there are sudden changes, again, in the hydrogen ion concentration, meaning that, say, there's a bunch of acids that have been made, the carbonic bicarbonate system will buffer and change in its little chemistry set formula, and then CO2 will be formed, and then that increase in CO2 will then be removed by the respiratory system. And the respiratory system is Johnny on the spot. It will react within minutes, and it can reach its maximum effectiveness in hours. So how does the respiratory system do this? Well, you know that the respiratory system rules CO2 and O2. We're talking about CO2, the acid, and the respiratory system will either increase the respiratory rate, and that will excrete or move out the CO2, remove the CO2, or it will increase the depth of the respiration, and that will also increase the removal of CO2. And again, if the respiratory rate or the respiratory depth decreases, then more CO2 is going to remain in the blood. And this is a very important concept for you to understand. So what is it that makes the respiratory system, the lungs, breathe faster, deeper, shorter, less, however? Well, the rate of respirations and the depth of respirations is controlled by the respiratory center in the brain, and this is also very important. In other words, as blood floats about in your head and it goes by the respiratory center that's located in the brain will go, I'm feeling or sensing that things are a little bit more acidotic than they should be. Lungs, you need to breathe faster and you need to breathe deeper. So the lungs are simply the tool. The brains, literally and figuratively, are the brains or the control behind the movement or work that the lungs actually perform. Now, what about the kidneys? How do the kidneys work? Well, the kidneys maintain the body's acid-base balance by either reabsorbing or excreting bicarbonate or by eliminating hydrogen ions. Now, let's say there is an acidotic state. So the kidney will then notice that the bicarbonate and the carbonic acid ratio, which is usually at a much higher bicarbonate ratio, it's usually 20 bicarbonates to 1 carbonic. And whenever the kidneys sense that, hey, this ratio is off balance, then the kidneys can also generate additional bicarbonate. The unfortunate thing is that it takes a while for the kidneys to recognize that a problem exists in the body. It takes the kidneys about 2 to 3 days to respond maximally. So again, lungs very quick, kidneys are a little bit slow. Now, when we talk about arterial blood gases, you know that to measure the arterial blood gas, blood has to be drawn from an artery, and then once blood is drawn, then the blood is put in a machine, and the measurement of pH, CO2, and bicarbonate is done. But what else is also measured, and that is the two things that are listed here. There's three, but the two other things that are measured are the PaO2 and the SaO2. And you have to know the difference between the two. So when we look at the PaO2, that stands for the partial oxygenate or partial pressure of oxygen in the artery. In other words, there are several different gases that are dissolved inside the blood, oxygen being one of them. And so when oxygen, the pressure, partial pressure of oxygen is measured, it's what's being kind of dissolved, what's dissolved in the blood. It is not recognizing the hemoglobin part, it's just what's dissolved in the blood. And that's why it's there. Now, you do not have to understand what I just said. What you have to know is you have to recognize that the PaO2, of course, it really tells you about your patient's oxygenation status, and you have to know that the value is between 80 and 100 millimeters of mercury. That's the piece you have to know, that normal is between 80 and 100. As opposed to the SaO2, this is oxygen saturation. So this does measure what the hemoglobin molecule, or how many of the hemoglobin molecules, and there's 4 of them on every hemoglobin molecule, how saturated it is. Are each of the 4 sites, are they carrying oxygen? And of course, if it's 100% saturated, then that means all of the hemoglobin sites are carrying an oxygen molecule. And so again, it's recognized by S is saturation, A of arterial blood, the oxygen of arterial blood saturation, and it will be identified by a percent. Again, do you have to know the specifics? No, but I want you to pay attention to the values, because students will often look at the PaO2 without thinking and think, oh my God, this patient's SaO2 or oxygen saturation is low. And so you have to really be careful of what you're looking at, so you know PaO2 value 80 to 100. Normal oxygen saturation is in this course, in the critical care course, is 90% or above. Now, this is a little different and annoying, I'm sure, from what you learned in J1 and J2, that 95% is normal. And when students ask Dr. Reed, well, what's the normal value for the critical care course, they're often not given a very specific answer. And so I'm going to tell you, after having looked at so many different exams, consider that 90% is a normal oxygen saturation, so between 90 and 100. Now again, the annoying part of that is these values, when you're doing ATI and when you're doing NCLEX, your standardized nursing tests, you have to go back to the 95%. So use 90 in the critical care course, otherwise you're going to have to go back to your gold standard from your J1 and J2 courses. Then we look at what is SpO2 and how does it differ? Well, it's really measuring the same thing. It's measuring non-invasively the oxygen saturation. How well are the hemoglobin sites saturated with oxygen? And you can tell the difference between the two because you see the oxygen saturation from the pulse oximetry. So again, Dr. Reed is not going to ask you the differences between these 3 items. It's not like you need to memorize it. I'm just telling you to be careful. I've seen it all the time where students look at the PaO2 and assume that a PaO2 of 80 is markedly abnormal because they're thinking of these 2 values. Now, the last question that I posed to you is, should you look at the base excess? And I say no. When you look at the base excess on the ABG values that might be given to you either in your practice questions or on the exam, I cannot even remember what the base excess normal value is. So you don't need to know it. Just ignore it because all you're going to do is look for values on the other mainstay items, and that's the pH, CO2, O2, and bicarbonate. Those are the things that you really should look at. Inquiring minds, if you want more information, then go find that in a source. Now let's look at some clinical examples. In other words, what are you going to be expected to do either on the test or when you're doing your critical care clinical? And that is you're going to have to look at the ABGs and kind of identify what's happening with your patient. What is their acid-base balance? Is it normal? Is it abnormal? And if it is abnormal, what's the cause of the abnormality? What's happening with the patient that is causing an abnormal ABG or acid-base state? So when you are interpreting blood gases, especially on an exam, my recommendation to you is to do what I say to you to do right now. Pause the recording, look at the ABGs, and then determine what acid-base state do I have, and then come back and look at what you're being asked about that acid-base state. Is what is the cause, or what is compensation, or what sign and symptom would you expect to see? Because if you try and configure everything in your head, you will get confused. Trust me on that one. All right, so let's look at this blood gas that I had printed or shown you on just the previous slide. Again, if you want to play along, pause the recording, configure the ABG, and then restart the recording. So when we look at the pH, we see that the pH value is less than 7.35. So we know that the pH is low, that this is an uncompensated acidosis state. Now, I always say that these are my ABG babies, and therefore the first and last name of my ABG baby is uncompensated acidosis. You may or may not have used the term uncompensated or compensated before, and so what's the difference? Well, anytime the pH is abnormal, it's an uncompensated blood gas. Anytime the pH is abnormal, it is an uncompensated blood gas. So we have a pH that is low, less than 735. We have an uncompensated acidosis. Now I say to you, well, who's the daddy of the ABG baby? Is it Mr. Respiratory or is it Mr. Metabolic? And we know that respiratory is or rules CO2. So we look at the CO2 and we see that the CO2 is 50. The normal value for the PaCO2, and I'm just going to say CO2 because it's too many words to say PaCO2, and the CO2 is 50. Normal is 35 to 45, a very easy number to remember because it's the same as the pH without the 7. So we have an elevated CO2. Now I look at Mr. Metabolic. Mr. Metabolic is linked to the bicarbonate, and we have, and when we say metabolic, we really do mean kidney, because really we call it metabolic because anything outside of the respiratory system is deemed metabolic, but the majority of actions that are done in the metabolic system are done by the kidney, so we also think kidney. So bicarbonate we see is 24. Now there are sources that vary, but for my thinking, the normal bicarbonate is 22 to 28. So because the bicarbonate is 24, I put a sideways arrow because this is indicating to me in my brain and with my visual cues that this is a normal bicarbonate. Oops. And so therefore, now we need to figure out who is this ABG baby's daddy. Is it Mr. Metabolic or Mr. Respiratory? And to determine that, we use the acronym ROME. Respiratory opposite metabolic equal. Well, what does that mean? It means that you look at the arrows. And if you see an arrow that is by the metabolic indicator, which would be bicarbonate, and if it is equal to the arrow of the pH. So you look at the indicator, metabolic is indicated by bicarbonate. If that arrow that you use is equal to the pH value, then this would be a metabolic problem. And you see those arrows on equal. So we know without a doubt that this problem is not metabolic. Conversely, if you have a value with CO2, we know that that is ruled by the respiratory system, and therefore when we look at the value next to the CO2, we see that it is elevated and we see that the pH is low. Therefore, this follows or fits the mnemonic, and it is opposite direction arrows, and so therefore this patient has a uncompensated respiratory acidosis. Now, I want to point out to you that I have named this ABG strictly from these three items, the pH, the CO2, and the bicarbonate. I have named this ABG from these three items, but there's more on this ABG values, and that's the O2 status. The oxygenated status of your patient is considered as a separate problem. It is a separate problem or diagnose or label. And when we look at the PaO2, we see it's 63. Normal is 80 to 100. This patient has a low blood oxygen level, and it's definitely confirmed by the oxygen saturation of 85 because it should be at least 90. So we can definitely or now completely label this ABG as uncompensated respiratory acidosis with hypoxemia. Email me if you have any questions about this. Let's move on to the other questions that we were going to ask about our ABG. Once we've determined the naming of the ABG, now we've got to figure out, well, what would have caused the issue? And if you look back on those ABG values, it's pretty obvious. What's caused the issue? The respiratory acidosis and its retention of CO2. What would cause an individual to retain CO2? Not breathing. All right, so what would cause the patient not to have a very good respiratory effort? And it could be caused because the patient has an altered mental status, such as either they've overdosed on a drug, such as an opiate, which is in the news almost all the time these days, or let's say, for instance, they were beat about the head with a bat. And so therefore it could have altered the level of consciousness because of a head injury or a stroke or any other thing that can cause an altered level of consciousness. Why would this be? Why would an altered level of consciousness cause the respiratory rate to decrease or change? Well, because you know that the brain rules the respiratory system. It could also be that the patient is unable to get air or to breathe in because, say, there's a plastic bag over their head, or they have a respiratory failure problem, some kind of respiratory problem, and the lungs can't do the work of breathing. Now, what additional signs and symptoms related to the cause would you expect? In other words, this is a way of saying what clinical manifestations would be present when the patient has a respiratory acidosis. Well, because they're retaining CO2, we relate that they have very shallow, they have either weak, ineffective breaths, and I call that guppy breathing. So if you're a fisher person and you like to fish and you catch a fish and throw it up on the sidewalk or on the grass, what happens to that fish when it's out of water for quite some time? It'll kind of do that, open and close its mouth in an attempt to breathe. I call that guppy breathing. And again, I don't mean any disrespect. My mother died this past semester. I understand that loss can be very tragic for individuals, but you've got to get through the critical care course, and I know that when I say guppy breathing, that's going to stay in your head, and you're going to remember that. The individual could also retain CO2 for without any respirations, or a poor respiratory effort can cause altered mental status. So again, this means that either the bad breathing or poor breathing is caused because of a head problem, or when there is poor breathing and retention of CO2, this can alter the mental status. Individuals will often complain of dyspnea or a stated shortness of breath. They can have cyanosis if you, the nurse, are not very astute and don't pick up that they're having respiratory difficulty. And so then what compensatory mechanisms would you expect to see? Now, when we talk about compensatory, we're really talking about the body's natural compensation mechanism, those that occur on its own. And whenever there is a respiratory problem, compensation is going to be naturally performed by the and first. That's important. Compensation is going to be naturally performed and first performed by the opposite system. So if this is a respiratory problem, compensation is going to be by the kidneys, and the kidneys can do a whole lot of options. They can hold on to bicarbonate, they can make more, they can get rid of hydrogen ion. The problem with this is that this takes days. So you can't say to your patient, well, you need to bust a move here and breathe a little bit better, because your kidneys aren't going to compensate for a couple of days. We know that there must be an intervention. There must first be an assessment and identification of a problem exists, and then the nurse must intervene. So the last question I posed to you, that's really not on the every time you see an ABG list, you need to ask this question, and that isn't oxygen controlled by the respiratory rate? So a lot of students ask this question to me because I've talked a lot about the fact that CO2 retention and respiratory acidosis is all about the rate and depth of breathing. And so students will say, well, gosh, I thought when we inhale, we bring in O2. And that is true. Of course, you inhale, you bring in oxygen. But here's the thing with that. With each breath, you don't use all the oxygen you inhale. The body only uses about 15 to 25% of the oxygen that's in the blood. And so, therefore, that's why you can hold your breath, because if you hold your breath, then you've got some spare oxygen that can be used. So play along with me so that, again, I try and do stupid things or silly things so that you can remember this. So take a regular breath and then exhale. So you brought O2 in and then you exhaled CO2. Now take a deeper breath. Inhale, 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 and now exhale. You kind of identified that you did blow out more CO2 when you have a deeper breath. And so that's why I say to you, CO2 is really all about not only the rate of the breath, but also the depth of the breath. Now, again, as I said, you don't use all of the O2 that you have in your blood. So if you held your breath for a minute, so which would change first? Would the O2 decrease first, or would the CO2 increase first? And of course, you know the answer to this, hopefully, that the CO2 would increase first. It is very, very sensitive to changes in the respiratory pattern. And so if you're the premium UTA nurse, if you notice that your patient has a poor respiratory effort, the CO2 will be elevated, but you may not even have a change in your patient's O2 status if you respond and intervene very quickly. Email me if this is confusing. All right, let's look at another clinical example. There's the ABG values. Pause the recording if you're so inclined. And then for the rest of us, we're going to keep going and interpret this together. So we look first at the pH, and we see that the pH is 7.38. Woohoo! We have a normal pH, So this could be a normal ABG. But wait, then we look at the CO2, and we see that the CO2 is 50. The CO2 is elevated. By no means can we call this a normal ABG, because the definition of a normal ABG is all normal ABG values. We have an abnormal value, so we're going to have to call this something other than a normal ABG. What are we going to call that? Well, this is when you're going to change the first name of your ABG baby. We have a normal pH. So this is when we call that ABG compensated. Compensated. We call the ABG compensated because the pH is normal. We cannot call it a normal ABG because there's at least one abnormal value. Now we've got to figure out what's the last name of our ABG baby. Is it acidosis or is it alkalosis? How do we figure that out? And so whenever there's a compensated ABG, we use this triangle to help us. And so what I've put on the bottom part of the triangle is 7.35, that's the low end of normal, and 7.45, the high end of normal. And if you were the perfect person and you had the perfect ABG pH value, your pH would be 7.40. So that's the perfect value. And then I drew a line between all of these values. And when we look on the left side of the triangle, that is meant to represent the pH value of 7.35, 7.36, 3.7, 3.8, and 3.9. And if your compensated ABG value, ABG or pH value, if your pH value, your compensated pH value falls on the left side of the triangle, we're going to call it acidosis. If your pH value falls between 741, 42, 43, 44, or 45, we're going to list that as compensated alkalosis. Now, why is that? Why did I create this rule? Or I didn't really create it, but why has this rule been created? It's because your body is able to compensate whenever there's an abnormal pH in an effort to get that pH back up to normal so that the cells can work well. Your body's going to try and push that pH into a normal range. And when your body compensates, your body's very smart. It will compensate until the job gets done. In other words, until it just pushes that pH into the normal range. At acidotic state, when there is an acidotic state, your body is not going to overachieve and try and compensate all the way over to this other side of the triangle. So the rule that you can always list is that whenever it falls on this side, the pH falls on this side of the value lines, then this is a compensated acidosis, and on the right, it's a compensated alkalosis. So now let's go back to our pH, where we see that the pH was normal, but the PCO2 is abnormal. We cannot call this a normal ABG, and so therefore, because the pH is normal and the rest are abnormal or something's abnormal, we're going to call this compensated. And we're going to actually say, because it falls on the left-hand side of the triangle, that this is a compensated acidosis. A compensated acidosis. Now, we previously identified that the CO2 is 50, the CO2 is elevated, and then we look at the bicarbonate, and we see that the bicarbonate is elevated. So now we're going, okay, who's the daddy of this ABG baby? Is it Mr. Respiratory? Is it Mr. Metabolic? And this is, again, where we look at the respiratory opposite, metabolic equal, and we look at our arrows, and we see that when we look at the metabolic component, the bicarb, we see that the arrow is going up. And we look at the pH, that arrow's down. That does not fit with metabolic equal. This is not a metabolic problem. Then we look at the CO2. And we see that the CO2, which is linked to respiratory, is increased. And then when we look at that in relation to the pH, we can see that those arrows fit. Respiratory is opposite. So this is a compensated acidosis. So what's the deal with the bicarbonate? Why is it abnormal? Because what has happened is that the kidneys have had time to respond. We don't know how long this has been going on. I didn't say one way or the other, or we weren't told. We know that because the kidneys are able to respond within a few days, that this individual has probably had this CO2 elevation for quite some time. The kidneys have had time to get into the program of compensation, and by doing so, they have either held on to bicarbonate or they have made more. And so what you see here is an increase in the bicarbonate because it is an effort by the kidneys to compensate for the poor respiratory program here. And that is what has pushed your pH into the normal realm. So that pretty much sums up the ABG itself. We have a compensated respiratory acidosis, but remember, we then have to look at the oxygenation status of the patient. And we see that the PaO2 is 81, So that falls within the normal range between 80 and 100, and that the oxygen saturation is 90%, which, madly enough, in our course, in the critical care course, it is considered a normal or acceptable value. So the patient does not have hypoxemia. So when we talk about what caused the issue, again, you can look at this again and identify. It's the same as what we've already identified, so I'm not going to regurgitate this information again. But what I want to do is note to you, so what kind of scenario would have played out? So what kind of problem would have or could have occurred in your patient that would have caused the ABGs to look like this? And the answer to the question is that there is a problem that has caused respiratory or a respiratory problem that has caused CO2 retention. And again, we have metabolic compensation. So likely this is a very typical profile of the chronic obstructive pulmonary disease patient. In other words, a patient that has either chronic bronchitis or emphysema, that's COPD. And by the nature or the pathophysiology of their disease or of their illness, these individuals retain CO2, and they don't do it for a day, they do it chronically. And because this is a chronic situation, then the kidneys usually have had time to sense this problem and they're able to compensate on a daily basis. And so that ABG is very, very typical of a COPD patient, including the oxygenation status. These people, they kind of walk around and live as a semi-anaerobe. They have enough O2 to get them through the day, but not a whole lot to strike up the band. Email me if you have questions. Moving on to the next ABG, we see that the pH is 7.38. We see a PCO2 of 27. So we see that the pH is normal, but the CO2 is low. We cannot call this a normal ABG, and so therefore we're going to list this as a compensated, and we're going to have to figure out what's the problem. What's the problem? So that's when we go back to our triangle, and we see that 7.38 falls on the left-hand side of the triangle. So when we go back to this, we identify that this is a compensated acidosis. We have a compensated acidosis. Now we got to figure out who's the daddy? Who's the daddy of this ABG baby? Is it Mr. Respiratory or Mr. Metabolic? So we look at the PCO2 and we see that the PCO2 is down and we see that the bicarbonate is down. Now we got to figure out which one is the problem. Which one is the problem? So we're going to look at the arrows, and we look at the CO2 arrow. The arrow for CO2 that is linked to Mr. Respiratory is low, is down, and as is the pH. We do not have respiratory opposite. This cannot be a respiratory cause of this abnormal ABG. Then we look at the bicarbonate and we see that the bicarbonate is low. The arrow is pointing down. The arrow to the pH is pointing down. We have a match. We have the metabolic is equal. These arrows match, and so therefore we can identify that this is a compensated metabolic acidosis, and compensation has occurred by the respiratory system, which we know acts or reacts within minutes by increasing the respiratory rate and or increasing the respiratory depth, and we are blowing off CO2. Then we look at the oxygenation status of this patient and we see, wow, the PaO2 is 271. Well, we'd say that's good. And then the oxygen saturation is 99%. So this individual has compensated metabolic acidosis with excellent oxygenation. Now, a lot of students will say to me, how can you have a PaO2 of 271? I thought the range was 80 to 100. And that is true. The range is 80 to 100. But if the patient is on supplemental oxygen, and by that I mean that if you and I are right now breathing 21%, which is room air, then if you add extra oxygen to your patient, so if you put your patient on 60 or 70% extra oxygen, then that can raise the PaO2. that can raise the PaO2. So why would a nurse do this? Well, patients come in and they don't have a placard in front of them that says, hey, I'm breathing okay. I just have some kind of metabolic problem. Well, you just see that their respiratory rate is very, very rapid, and so you just assume that it could be a respiratory problem, and so you slap some O2 on them because that's what you were taught in J1. Let's just give somebody O2 because it's not going to hurt them. And it is a physics thing of how the PaO2 can increase, none of which you need to know unless you go to medical school. But you just know that your patient has excellent oxygenation and you can probably take that O2 mask off. So what caused the problem with the metabolic acidosis? Well, it's because there's been too much acid production. So let's look at this. What kind of problem can occur with too much acid production? And you should know DKA pretty well from J2 semester. If an individual ingests some poison, renal failure, diarrhea, tissue hypoxia. Wait a minute, students will ask. Hypoxia? How does hypoxia, which is a breathing thing, how does that produce a metabolic acidosis? Well, I want you to go back to your patho notes and or the notes in the Hughes Clues concepts, and you have tissue oxygenation, or oxygen is needed by the tissue to do its metabolic functions, to make ATP, and whenever there is no oxygen available, then the cell can't really do its job. It can't make ATP. The only thing it can do is do a little bit of work, and it goes into anaerobic metabolism, and the byproduct of that is lactic acid. Dr. Reed is not going to ask you the dirty details about tissue hypoxia and lactic acid. For those inquiring minds who do want to know the details, email me. And what additional signs and symptoms would be related? Of course, if you had a metabolic acidosis, because as I mentioned above, there's so many different reasons how you can have a metabolic acidosis, the signs and symptoms are way too varied. If you have edema from renal failure, you can have acetone breath from DKA. Now, what compensatory mechanisms would you expect to see? And again, we know that for every problem that occurs, if it's in the metabolic system, then the respiratory is first to compensate. And if it's a respiratory problem, then the metabolic system compensates. So we had a metabolic acidosis. Respiratory compensation will occur immediately, and the respiratory system rules CO2, which is an acid, so therefore the respiratory system wants to get rid of that acid, and so the respirations will be deep and rapid, and you should know this to be described as Kussmaul respirations. Moving on to the next ABG. pH is 7.11. Well, that's pretty easy. That is decreased. It's less than 7.35. We know that this patient has an uncompensated, because of an abnormal pH, acidosis. Now we got to figure out who's the daddy, who's at fault. Is it Mr. Respiratory or Mr. Metabolic? And we look first at the CO2, and it's low. It's 18. It's less than 35. Then we look at the bicarbonate. It's 6. Well, that's definitely low. It's less than 22. And then we can identify that who is or where is the link. So we look first at the respiratory system. We see the arrow going down. We see the arrow going down. That does not configure with our mnemonic. It is not, the arrows are not opposite each other, and therefore this cannot be a respiratory problem. Let's look at the metabolic system. We see that the bicarbonate is low. It is down, the arrow is down, and that does match with the arrow to the pH. So this is a metabolic equal. We have a uncompensated metabolic acidosis. Then we look at the patient's oxygenation status, and we see, great, PaO2 is wonderful, and the SaO2 is wonderful. So they do not have an oxygenation issue. So I know this is pretty much a repeat of what you already know, but I just want to show you how fast the respiratory system works. That's why that CO2 is so low. But evidently it's not doing the job well enough because the patient is still profoundly acidotic. So we know that acidosis, when acidosis can occur, this could cause your patient to be profoundly ill because the respiratory system is just not able to cope. And with that in mind, we're going to do a little scenario here that a patient that presents with something that you would expect to see. These are the ABGs that we just reviewed, a metabolic acidosis because of a diabetic ketoacidosis problem. And the other signs and symptoms that are present are polyuria, and a potassium level of 3.4 is noted on the nurse's assessment. So, of course, treatment for a metabolic acidosis is sodium bicarbonate. And so the physician or nurse practitioner prescribe a sodium bicarbonate drip. And then 2 hours after the drip has been initiated, the nurse identifies an abnormal cardiac rhythm. So what is the cause of this complication to your patient? So they have a metabolic acidosis and now they have a cardiac problem. So let's use this as a clinical example of the pathophys that you already know, that as soon as a metabolic acid occurs, and I don't mean a metabolic acidosis, it could have been a respiratory acidosis. It really doesn't matter whether it's a metabolic or a respiratory, but because our scenario reads a metabolic problem, as soon as acidosis occurs, the cell acts as a buffer. And it acts as a buffer by moving the excess hydrogen ions into the cell, and in exchange, the cell will kick out potassium. But because of this patient's illness with diabetic ketoacidosis and the polyuria that accompanies diabetic ketoacidosis, the patient has lost a lot of potassium with all of that urine. And the potassium level is low. It is slightly low. And as the sodium bicarbonate is infusing, that's going to raise the pH. And as soon as the pH starts going up, well, then the cell will stop acting as a buffer and the cell will kick out the hydrogen ions. And so those move out of the cell. And then in exchange, the potassium ions will go back into the cell. And so this will cause the potassium level to decrease even lower than the 3.4 that was present on admission. And so this is what can occur when treatment is initiated. The physician or the nurse should have identified that, you know what, this is going to happen whenever that acidosis is reversed and said or treated. And so this is why you got to learn this stuff, is because you have to watch and be an advocate for your patient whenever the physician doesn't quite connect it. You have to. So there's your clinical note that if your patient is acidotic and hypokalemia, you better be cautious and really treat that, or concurrently treat the potassium and the acidosis at the same time. Email me with questions. Let's do another ABG. We've got a pH of 7.25. That pH is less than 7.35. It's low. Now we look at the CO2. The CO2 is 47. The CO2, we should have identified the name of this ABG. And we see that the name of our ABG is uncompensated acidosis. And now we see that the CO2 is 47. And when we look at that, we know that that is greater than 45, so we can put an arrow going up. The CO2 is elevated. So then we see that the bicarbonate is 19. The bicarbonate is 19. It is less than 22, therefore the bicarbonate is low. And now we've got to determine who's the ABG daddy. Which problem is occurring? Is this a respiratory problem or is this a metabolic problem? And so let's look first at the CO2, which is linked to respiratory. We see that the arrow is going up. To the pH arrow that is down, we have respiratory opposite. We have a respiratory acidosis. Then we look at the bicarbonate and we see that the arrow is down. And we look at the pH arrow and it also is going down. So we do have the rule metabolics equal, which means that our our ABG problem is an uncompensated respiratory and metabolic acidosis. A respiratory and metabolic acidosis. And when we look at the oxygenation status of the patient, the PaO2 is 69, markedly low, as is the oxygen saturation. So this patient has an uncompensated respiratory and metabolic acidosis with hypoxemia. So what caused the issue? Again, too much acid production. It could be DKA, and anytime there is a abnormal pH, then we know that the cells don't work very well. So maybe the brain cell caused the patient to not breathe very well, and so therefore the patient is not able to bring in CO2, and if it went on for a long enough period of time, maybe they're not bringing in O2. So we can categorically say that the metabolic system and the respiratory systems are both broken. They are both broken. So what additional signs and symptoms would you expect? Well, I can guarantee you that this patient will have altered mental status, and that's usually what brings in very ill patients. His family brings them in because they are confused or they're acting oddly. Otherwise, there would be a whole lot of different vital signs depending on what signs and symptoms or clinical manifestations, depending on what's identified as the cause. Oh, what about compensatory mechanism? Well, this is a problem because the renal and the respiratory systems are the problem, and they're both broken. So the patient lacks the ability to compensate. And that's what makes a patient critically ill and the purpose of this course. This patient will likely need respiratory support with mechanical ventilation and will likely need renal support, perhaps with dialysis. So that is really the definition of a critical patient, one who has multiple systems broken. So comorbidities is the fancy way of saying that. Now, I really have given you a whole lot of information, and I know it's at this point in the presentation that you're like, enough already. But I would like to point out that in your in your ABG worksheet, I've put this grid on one of the documents, and you can see that it's essentially identifying, I call it the ABG grid. It's essentially identifying each of the abnormal acid-base states and what you can expect to see, signs and symptoms, and compensation and treatment. And then in this middle bar right here, I've identified to you the signs and symptoms of acidosis because there are some common signs and symptoms, whether it's a respiratory or metabolic acidosis, that you do see, and the same with alkalosis. So you might want to look at that because, again, anything is fodder for an exam by Dr. Reed. Now, again, it's a lot of information, and I highly recommend that you don't memorize it, that you write this down on what I call your exam cheat sheet. Dr. Reed, in the past, I don't know, at least 15 semesters, has allowed students to bring in a cheat sheet. So in other words, a note page, and you can put this on your note page. I will also caution you, because this is the first time it might have been mentioned that you will have an exam sheet, is that Dr. Reed will give you an entire length or page full of rules when you bring in your cheat sheet, and you better follow them to the letter, or the Nazi proctors will take it away from you and you may just cry. So be sure and follow the rules, but do put this ABG grid on the exam sheet to kind of help you with this confusing material. If you have any more questions, be sure and email me. I strongly encourage you to do some practice ABGs. I have several written for you on the ABG worksheet, as well as an online practice source. I hope this has been helpful.